part of a committee led by WHO looking at recommendation on hepatitis C self-testing. And the initial suggestion was that since we have a lot of evidence from HIV, we could just, transfer this results, these findings from HIV to hepatitis C. But, then we argue that not much of the research done on HIV was with injecting drug user. So there was a lot of scope for doing something different. So the purpose of this webinar and why we're here is really to talk about why we should engage in research and not be shy or afraid about it. And that's because research has been setting up trials for a maximum outcome and not much representation historically, and have been excluding specific population, especially people who use drug, homeless people, pregnant women, ethnic minorities, for a very simple reason, because that in the eye of the researcher not reliable, they're very likely to drop out. So since all research now is done on an intent to treat basis, this will affect the result of the trial. But the bottom line is that the very same population which the specific drug or intervention is going to be used are excluded by design from research. But since at least in 20 years, starting with the cancer movement, the women movement, and most importantly, it is most visibly the AIDS movement, there was a successful attempt to reframe research through direct engagement in the construction of knowledge, deconstruction of science, and by reclaiming the role of lay people in setting up the research agenda and analyze the data that will turn in policy. And that's one of the reasons why we argue that it's really important for us to engage, because a lot of policies that deal with public health especially are built on evidence, can be built in a way that will support specific piece of policy. So we usually engage the level of policy, but actually at that point there's a lot of information that have not been influenced by our presence, our advocacy. Despite the notion of science as a autonomous field with high barriers to entry, and when I say barriers to entry, talk about language, about privileges by researchers, and the intentional use of a complicated language that's designed to keep people away. Activists have been participants, and they've been pushing, demanding to be part of the scientific discussion and the construction of scientific knowledge, and especially on the setting up the narrative that come up from this research, these pieces of evidence. So treatment activism is nothing new. As I was mentioned before, most well-known and visible was the AIDS treatment activism from the late 80s, early 90s. And that's where activists began to push for specific changes in policy, especially rapid approval of experimental treatment, because at that time, the point is just, people are going to die anyway. So I was slowing down approval of treatment that may be useful. So by the late 80s, the movement switched from, looking at the early stages of development of drugs because of growing concern about the ethics of clinical research. And, as you can see from the quote below, is really, at that time was seen as a matter of survival. So the point was, there are a lot of people, they have a huge stake in terms of financial gains or, policy goals, but, and everybody's at the table, but it was really important to have people at that time, people living with HIV, being also at the table and being able to affect all the discussion, because they were actually the people that the most at stake in all this process. So just looking at the history, we talking about a period where there was not much available, and most of the available option was just ineffective. A lot of governmental agency or pharmaceutical company were not making much effort in that field. Only some basic biological research was funded. So there was a lack of interest, lack of urgency from the establishment, or the people that are traditionally supposed to influence and be engaged in clinical research. As a response, community organized small clinical trial. They were just led and originated by a community looking at exotic experimental compound, leading to actually important findings, looking at some of the initial development of HIV treatment, with support of some physicians, some community-based organization started or undertook the first treatment trial in the AIDS field, leading to the very early approval of AZT that then we found out was not very effective. But there was a lot of pressure for the community to start using it, and providing a lot of people willing to use it, and moving the whole discussion around early access to treatment and engagement of a community in clinical trial design, implementation, and evaluation as one of the key elements of the AIDS response. So now here we're talking about what a lot of people call evidence-based advocacy. So just basing our advocacy on evidence, and we want to be engaged in the production of knowledge and evidence. And yet, scientific evidence, as I mentioned before, is a powerful, or can be a powerful advocacy tool that activists can use to support their demands, build credibility, and get a seat at the table with policymakers and researchers. That evidence-based advocacy is research data to inform better policies. So we have a very, we have an interest in being part of it, because we understand that evidence is the first step informing advocacy that is affecting our life. And we usually engage at the level of policy making, but at that point, a lot of call have been made that when interpreting study, it can be very easy for people to become overwhelmed. That's, by design, that's what people want us to be, to feel overwhelmed and incompetent and unable to deal with the jargon and all the technicalities. But actually, what we're bringing into the clinical research process is something that is almost impossible to learn, while we can learn as, generation of activists from different fields have been doing. We can learn the scientific language and deconstruct science, make it more easy to understand, and that's a way to fight against a system that is designed to preserve a system of powers like science. So in terms of and this is something we through addressing some studies, especially from Eastern Europe and Central Asia, that have been dealing with this, and the study we're referring to, which is linked to hepatitis C self-testing. There are 16 that would like to address as a point for discussion. First, we want to build our legitimacy with those who are aiming to influence advocating for. It's important as a community to be a bridge, and especially to act as an interpreter and trying to deconstruct and make the scientific language understandable to our community, because it was designed not to be understandable, but it can be made understandable. So of course we want to understand, but also demand a place at the table with people who can influence, especially academia and researcher. And well, mostly like, it's just about really playing the long game, because there's, a long-term investment within our community to build capacity and knowledge and the ability to engage in research, building on, some people that part of our community are researcher, because, that's the job in life, but also we can learn and deconstruct science in a way that is transferable. And most importantly, as usual, for everything, just to pass the torch, do it in a way that can be transferred to other people, and build leadership and competence and knowledge across the continuum of the work we do. And that's all I have to say as an introduction. And I will now pass the presentation and the mic to I think Sergey, that will that will talk us through some example of how community engagement can add a lot of value in research, and especially how this is important to us. Sergey.
Привет, слышно?
Да, да, Серега.
О, свои люди.
Да,
Здравствуйте
мы
всем.
здесь, братуха.
Меня зовут Сергей Бессонов. Я представляю Ассоциацию «Сеть снижения вреда» в Кыргызстане и людей, употребляющих наркотики. Спасибо, Мауро, за вступление. Я продолжу, наверное, уже в таком контексте страновом, да, то есть я хочу рассказать о нашем опыте участия в исследованиях. Следующий слайд.
Mauro, next, please.
Next, please, slide. В Кыргызстане мы смогли изменить чисто научный подход при проведении исследований, добившись ключевой роли самих сообществ людей, употребляющих наркотики в исследованиях, от момента их инициирования до этапа анализа собранных данных и их использования в целях адвокации так, чтобы основными бенефициарами были мы сами, то есть люди, употребляющие наркотики. Чуть-чуть, может быть, я скажу, что это звучит утвердительно, но все-таки мы находимся на этом этапе, и я думаю, мы его одолеем. То есть мы смогли добиться неких высоких результатов при проведении исследований силами сообществ, изменив традиционный путь, использованный при проведении медицинских исследований, которые стараются сохранить привилегии тех, у кого есть возможность доминировать и не учитывать мнение тех, кто не является официальными экспертами. Мы проводим свои собственные исследования, и далее я хочу привести несколько примеров того, как наша работа могла повлиять и привела к укреплению безопасности, улучшению качества жизни нас самих. То есть мы надеемся, что другие сообщества людей, употребляющих наркотики, также будут проводить свои собственные исследования, направленные на улучшение качества их жизни и безопасности. Next slide. Первый пример, который бы я хотел, чтобы вы все видели, это у нас лет 7 назад началось такое массовое введение налоксона в страну, и это был первый проект глобального фонда, который подразумевал только закуп препарата и его раздачу. На слайде вы видите результаты такого внедрения, то есть 86%, да, это... Маура, next slide. Это те ампулы, то есть, диаграмма была лишь одной из 70 диаграмм, которые мы использовали, и таблицы там, которые можно было отследить результат. Факт в том, что это проводили не сообщества, они в нем не участвовали и не координировали. А одной этой диаграммы, достаточно, чтобы понять, какой важный пробел произошел в организации этих услуг в наркологической системе. Оказалось, что вот 86% ампул, они были просто утеряны или разбиты, то есть, истрачены неэффективно. Что мы делали дальше? Next slide, мало. Мы тоже взялись за такой проект, мы осуществляли его в прошлом году. Это был проект СОС, то есть наша организация с позиции сообщества рассмотрела, как лучше сделать так, чтобы ампулы не терялись, чтобы они не ломались и чтобы они эффективнее использовались самими наркопотребителями. После нескольких фокус-групп мы выяснили, что люди все равно их не носят, они хранят их в определенных местах. Также у нас есть социальное общежитие, где наши люди находятся. Мы взяли простые кабель-каналы, это каналы, кабель-каналы пластиковые, предусмотрены для проведения проводки. Они довольно дешевые, простые, вы видите на рисунках, как этот процесс длился. Мы их набрали, накупили, разрезали, сделали небольшие пеналы, которые помогли вместить туда 2 ампулы налоксона, 2 шприца, спиртовую салфетки. И сделали такие определенные наборы, которые бы могли сразу иметь под рукой люди при экстренной ситуации в случае передозировки. Next slide. Вот вы можете видеть на нем, каков был набор, каково было содержимое этих наборов. То есть, помимо того, что я уже озвучил, были еще резиновые перчатки. Маура, next slide. Здесь у нас, конечно, был спор с некоторой возможностью этих перчаток. То есть, к сожалению, мы не смогли убедить спонсоров удалить из содержимого пеналов резиновые перчатки, заменив их на что-то более ценное для потенциальных потребителей. Мы приводили в качестве аргумента анализ данных, собранных во время фокус-групп, организованных нашей организацией, из которого следовало, что потребители предпочитают использовать перчатки в качестве жгута во время инъекции, а не по прямому назначению. Были проблемы с тем, чтобы эта коробочка, этот пенал не был слишком большой, чтобы он помещался в карман, чтобы его было удобно носить. Следующий слайд – это второй пример. То есть в Кыргызстане довольно активно развивается сейчас ситуация с употреблением новых психоактивных веществ, синтетических наркотиков. При этом программы глобального фонда никак не учитывают этих людей, ни потребности. И вы знаете, что буквально уже месяц-полтора как стартовал новый этап глобального фонда, где кто-то что-то говорит? Нет? Стартовал новый этап глобального фонда, и мы очень переживали по поводу того, что мы не сможем включить потребности этих людей. Нет, пока мы сидим на этом. Что что не будут учитаны потребности в следующий период, то есть последующие 3 года. И аргумент, как Мауро прежде говорил, был и состоял именно в том, что нету доказательных исследований, нету оценок, которые бы говорили, что эти люди есть и что они в чем-то нуждаются. И вот у нас 2020 год стал таким для нас, для нашей организации, он поворотным, потому что мы смогли провести несколько исследований, в том числе и по новым психоактивным веществам, и с помощью input, и в том числе с помощью Евразийской ассоциации снижения вреда получилось сделать это для молодых людей, потому как первая наша оценка, она начала указывать на то, что эти новые наркотики, они больше присущи молодым людям, и у них есть свои особенности, которые получилось выявить, и очень настоятельно для рабочей группы это указать. И даже если не в большом количестве, но в новую заявку глобального фонда включили пилотные проекты по работе с людьми, употребляющими новые психоактивные вещества, ну и в том числе привлечение молодежи. Next slide. Вот некоторые выводы, которые были сделаны по результатам анализа собранных данных, то есть люди, зависимые от новых психоактивных веществ, это в основном представители молодого поколения, они не имеют достаточного доступа ни к медицинским, ни к социальным, ни к правовым услугам, которые доступны у нас и в рамках глобального фонда, и в рамках других программ, работающих в стране. Решение было предложено сообществом людей, употребляющих наркотики, в том числе сделать проект, то есть между сетью снижения вреда в Кыргызстане совместно с фондом Глори. Этот фонд Данил, коллега мой здесь, он как раз представляет исследовательское направление. У нас получилась очень неплохая командная работа вместе с женской сетью ключевых сообществ. Мы сейчас приступили к разработке очередной версии вмешательства Винкс. То есть это программа, о которой Данил может еще упомянуть в своей презентации, которую он будет делать следом за ней. Ну, те ожидаемые результаты, которые мы хотим получить, это будут обученные люди по методике специалиста оказывать более эффективные услуги по профилактике домашнего и гендерного насилия женщинам, живущим с зависимостью от новых психоактивных веществ. Это будет новый проект, мы его хотим адаптировать, построить, и уверены, что это будет успешная идея и затея. То есть особенности, эта методика предполагает более усовершенствованный алгоритм работы с ближайшим окружением, со специалистами медицинских бригад, бригад скорой помощи, ну и с правоохранительными органами в том числе. Следующий слайд. Опыт Винкс. Эта работа строится на предыдущем опыте реализации проекта Винкс. После соответствующей адаптации различные версии этой модели доказали свою эффективность, особенно при оказании помощи женщинам, употребляющим наркотики, секс-работницам, а также тем людям, кто предпочитает получать помощь методом единого окна, когда весь комплекс медицинских, социальных, психологических и юридических услуг, он предоставляется в одной организации. Этот механизм освобождает женщину от необходимости самой искать людей, ответственных за обеспечение ее здоровья и безопасности. Следующий слайд. Третий пример – это в прошлом году мы также участвовали в проведении индекса стигмы. Это был региональный проект, он проводился и в Центральной Азии в общем, но наша организация участвовала именно в Кыргызстане. Мы успели до ковида провести, наверное, 80% полевых работ. Сейчас этот отчет заканчивается, и последние результаты будут буквально, наверное, в течение недели-двух уже показаны. Помимо этого, я бы хотел еще дополнить, что буквально на прошлой неделе, после вот этих проведенных нами встреч, Республиканский центр СПИД, он собирается в ближайшее время провести в стране оценку численности людей, употребляющих наркотики, и мы получили прямое приглашение участвовать в этом процессе, причем нас радует и удивляет, что мы получили его на самом начальном этапе, сейчас только планируется, сейчас только разрабатывается рабочая группа, и мы уже начинаем принимать там участие. Ну и те исследования, которые я сказал, мы делали по новым психоактивным веществам, мы собираемся их продолжать. Мы уже нашли некоторые моменты, которые будут однозначно интересны как для нас, так и для всех тех стейкхолдеров, кто здесь собирается работать с людьми, употребляющими наркотики. Ну и, наверное, все. Я вижу по времени, я вроде уложился ровно во столько, сколько мне отводилось, поэтому, насколько я понимаю, вопросы будут в конце встречи. Я передаю слово следующему оратору.
Саша, давай попробуем послушать Даниэля Вульфа, и он расскажет немножечко вот эту запись.
А ты мне говоришь?
Да. Maura, could you please, yeah, let me share the screen,
So this project is important to me, and I think to the world for two reasons. First is that it is highlighting not only a problem of gender-based violence and intimate partner violence, but what people can do about it, and what people can do about it who are often left by themselves to cope. So that's incredibly important. The second reason why it's important is that it represents a collaboration between civil society organizations, a leading research university in the world, and an NGO that is to help bridge the gap between those. And in that way, I think it represents a model not just on women and violence help, but also on how collaboration can look in Kyrgyzstan and elsewhere.
Отлично. Молодцы.
All right, no, thank you. Thank you very much, Sergey. So now we're moving into a presentation really address the content and the result and the spirit of these country research focusing on acceptability, values and practice on hepatitis C self-testing. So we have three presenters going through, well, first Daniel introducing the whole study and talking about the Kyrgyzstan component, and then we move into the South African component, then Costa Rica. They were different because a number of reasons that Ernesto will share with you. I will really invite presenter to keep the whole thing around 15-ish minutes, so we can at least 10 minutes for Q&A, which is, you know, usually the most interesting part of the webinar. Daniel?
Yeah, go ahead, Mauro. Go to next slide.
Wait, okay, yes.
Well, the study aims were pretty much similar in all three countries, in Costa Rica, in South Africa, and in Kyrgyzstan. We were hired to assess the values and preferences surrounding hepatitis C self-testing. We were supposed to provide recommendations and perspectives from the community to inform future implementation of the hepatitis C self-testing program. We also tried to incorporate opioid overdose education and training when we conducted meetings with the communities. Mauro, next slide, please. Well, project life cycle, I mean, all the points were pretty much common sense. I mean, three phases, traditional three phases: preparation phase, implementation phase, and wrap-up phase. In the preparation phase, we formed the project working group. I mean, in all three countries, it was the same. We selected implementing partners. Absolutely important point. Well, we all know that. Assessment protocol adjustment and obtaining the local IRB approval also took some time. Then we went to project detail planning and implementation and staff training. Then we started conducting semi-structured individual and semi-structured group interviews. We conducted participatory action research exercises. Then we conducted thematic analysis and provided synopsis report. The report, well, all the activities, field activities, they focused on describing awareness and attitude of the communities towards hepatitis C self-testing, its acceptability, modes of communication and delivery, challenges and concerns, supervised versus unsupervised self-testing, affordability and packaging, and change in risk behavior. Thank you, Mauro. Next slide, please. In Kyrgyzstan, we conducted individual and group interviews in Bishkek. Well, actually, we engaged drug users from Bishkek and Chuy region, which are suburb and rural areas around Bishkek. We conducted group and individual interviews with total number of participants, well, 47 participants were engaged. Eligibility criteria of the participants were: they had to be at least 18 years old, they had to speak and understand Russian, they had to self-identify as people who inject drugs, they had to have some HCV-specific experience and knowledge useful for operational purposes, and they had to be able to complete informed consent. Of course, they had to be willing to share their insights to improve operations. Mauro, next, please. Awareness and attitude. They interviewed people who injected drugs. Well, total number was 27. They demonstrated proper awareness with respect to the concepts of hepatitis C. What was interesting is that while communicating with us, they always referred to HIV self-testing, HIV procedures, rather than HCV. So they wanted to, well, probably demonstrate the similarity between those two, between testing approaches for HIV and HCV. Acceptability, all informants, well, all 47, all of them, they appreciated the idea of allowing people to have access to hepatitis C self-testing. Next, please, Mauro. Next. Modes of communication and delivery. So the first preference of all the respondents was to have access to hepatitis C self-testing through the non-government community-based organization, harm reduction agency, that would also provide them access for some medication if available through international donor. The second choice was the private clinics and then the government clinics. Mentioned challenging, of course, missing privacy and confidentiality. According to the informants, it created another risk to other people who were around them. So recommended measures. So they had to, they advised to produce leaflets, paper-based information brochures, videos, video tutorials. They suggested to have some online resource center and some websites available 7 days per week, all day round. Thank you, Mauro. Next, please. Challenges and concern. Of course, finance issues, because people were not sure that hepatitis C self-testing would be free of charge. The stigma and discrimination demonstrated by poorly trained medical personnel. Psychological discomfort, and myths and lack of information about hepatitis C. All these challenges were just disclosed by all the participants. Well, solutions suggested: friendly navigation by peers, brief counseling by pharmacists, and it was pretty new to us. It was introducing hepatitis C self-testing in prison settings. Well, people who inject drugs, they mentioned that nowadays people, or HIV positive people, they live under the law on AIDS, law on AIDS, law on HIV. So there is some law, some legislation that describes their, well, the context in which they have to survive. So differently from that, people with hepatitis C, they do not have such legislation developed. And they suggested that the government develop some kind of law on hepatitis C that would describe all the legislation framework. Next slide, please. Well, and please, let's skip this and let's go to next slide. And next one. Thank you, Mauro. So the cost for all the selected recommendations are here. The cost for testing services has to be covered by the medical insurance. This was the idea suggested by our respondents. Key populations have to be eligible to this medical insurance. Medical professionals have to be further trained to minimize stigma and neglect towards clients with HCV. Harm Reduction Network and Community Advisory Board under the Ministry of Health have to mobilize civil activists, NGO leaders, and medical professionals for developing proper training materials on how HCV self-testing can be used. People have to be properly informed of diverse testing and treatment solutions, and their decisions have to be fairly informed. Information does not have to be limited by Kyrgyzstan, but be applied globally, like the case of vaccination. Some sort of association, some sort of network for people living with HCV also would be helpful. Design the law on HCV that would be similar to the existing law on AIDS, where the procedures, subsidies, and privileges would be detailed. It would be pretty helpful. Effort have to be undertaken to engage the prison management authority for developing proper testing and treatment protocol applicable for in-prison framework. Thank you very much. It was the Kyrgyz scope. Thank you, Mauro.
Hi, yes, good afternoon, everyone. My name is Michael Wilson, and I work for an organization called Advanced Access and Delivery. And in close partnership with the South African Network of People Who Use Drugs and TB HIV Care, my colleague Torres Luna and I led the field work for this assessment here in Durban, South Africa. Over the next 5 minutes, I would like to share an overview of the assessment results and some of the key preferences and recommendations that emerge from this assessment. So just to give a quick overview, our assessment engaged a total of 47 individuals. The team conducted individual interviews with 24 individuals. We had 11 participants that participated in group interviews, and we had 12 individuals participate as part of the PAR sessions. All of the individuals that participated in the assessment here in Durban were homeless at the time of the interview, and the average age was 29 years old. The data collection was carried out between September to middle of October of last year, and all of the activities were conducted face-to-face. The individual interviews and the group interviews were conducted at a drop-in center run by TB HIV Care, and the PAR exercise was conducted at our office, which is a few blocks away from a harm reduction center called the Belhaven Harm Reduction Center. All of the individuals were compensated 100 Rand for their time, and they also received overdose awareness and training as part of the exercise. So I think we can move to the next slide. So our assessment suggested that there is moderate knowledge of hepatitis C amongst the informants. Less than half of the informants reported that HCV spread through exposure to blood, sharing needles, unprotected sex. The informants said that HCV is not widely talked about as a topic in the drug use community, and several times mentioned that HIV and TB were more often a point of conversation than hepatitis C. They said that when hepatitis C is discussed, that it's often described as a low-class illness or one that is suffered by people that are in extreme poverty. The quote at the bottom reads, "In my community, it's not really educated about, as opposed to AIDS, which the focus is more on, and less on hepatitis, which is as serious as AIDS." Next slide, please. Testing for hepatitis C was described as infrequent compared to that of HIV or screening for tuberculosis. There was general agreement that for individuals engaging in sharing needles or having sex with somebody that they don't know their status, that they should receive regular testing. Many of the participants reported advantages to a hepatitis C self-test that were related to their privacy, a savings of time, and affordability that it could offer, which were commonly reported as issues that impede access to conventional hepatitis C testing at community clinics or hospitals for the drug use community. Another advantage that was accelerated was linkage to treatment and care that the self-test would offer, particularly if provided by a trusted service provider, such as an organization that may run a drop-in center or may already work with people who inject drugs and have an established history of working with this community. There were differing opinions on the acceptability of specimen for testing. Some preferred an oral specimen for its ease of use, while others felt like hepatitis C results from an oral specimen may not be as trustworthy as blood. Blood was described as some as more pure or more accurate, and generally informants expressed comfort in drawing their own blood given their daily interaction with needles and syringes. There was generally a consensus amongst the informants that while there should be a variety of ways to access a hepatitis C self-test, including through trusted pharmacies or clinics or community-based NGOs, that there should be some sort of mechanism for delivering tests to hotspots where people who inject drugs gather, where they spend time, or where they frequent, including drop-in centers or harm reduction centers. You can please move to the next slide. Participants highlighted the importance of considering their time and their location when delivering a hepatitis C self-test. And when asked where the test should be made available and how, I just pulled these three quotes from our data that I just wanted to read. So when asked where they should be delivered, one individual said, "Where we are, meet drug users where they are in the hotspots once or twice a week, handing out tests and educating people." Another man mentioned that the service delivery should be set up next to the drug sellers where we go every day on our route. This should be where people get it. It's not out of the way. And then the third individual said, if you are using needles and are at a risk, then you would get the self-test for hepatitis C with a pack. It would be paired together with services that we already get from drop-in centers, suggesting that it should be a package of our services that are already offered to this group. Next slide, please. Some of the key concerns that came up throughout the assessment were related to the competing priorities and the time constraints facing people who inject drugs when it comes to accessing health services. One participant said, "Time is money, drugs aren't cheap, and leaving our post is hard." While supportive of the self-test, many described the ideal test as one that would minimize time and financial impact and would be made available along transit corridors that are used on a daily basis. Fear and stress as a result of receiving a reactive hepatitis C self-test result was a common concern of many of the participants, particularly paired with little knowledge of hepatitis C and discussion of how to access the next steps and the care. Next slide, please. Based on the challenges brought up, some of the selected recommendations that we pulled, one was to improve knowledge and awareness of hepatitis C, particularly around how it is transmitted, what are the risk factors, and who are the high-risk groups. Strategies to raise awareness should be well thought out, and particularly around reducing the stigma that is associated with hepatitis C across the broader community. Another key recommendation was around considering delivery options that are low threshold, that meet people where they are and limit the time and the financial strain on accessing the test. Another recommendation was delivery of hepatitis C self-test should be thoughtfully linked with existing services, as I just mentioned, with organizations, again, that have established rapport and relationships with this community. There also should be efforts to advocate at the community level with staff from clinics and hospitals around the issues that impact access to care for people who inject drugs. And lastly, considering lessons from HIV and tuberculosis towards increased community awareness and acceptance of hepatitis C. And then just lastly, we have a video that we were given permission by the individual that is in the video to show you all, but it is part of the final piece of this assessment that we did, and it was to provide some education and awareness around drug overdose. And part of that package was to provide naloxone and training on how to recognize the signs and symptoms and to respond to a drug overdose. And so we just wanted to share this video with you all.
No sound.
Sorry for that. I realized that you couldn't hear
Oh, yes, sure.
as video. So can we move
Just
to
this.
Ernesto?
Okay. Hello, everyone. Thanks for being here. So many peers from all around the world. This is excellent. My name is Ernesto Cortés. I'm an anthropologist. I'm a drug user from Costa Rica. I work at ASEID, that is the Costa Rican Association on Drug Studies and Intervention. And I'm also a member of LAMPET, Latin American Network of People Who Use Drugs. So first, I don't want to go much through the research, as my colleagues talk about it a lot. And I think results are fairly similar. So I'm going to focus more on the process and characteristics of Costa Rica. So this is the objectives of the research. The main difference we have in Costa Rica is that we didn't work with people who inject drugs. We work with people who use cocaine or crack cocaine because injecting, it's not a common practice in my country, in most of Latin America, in fact. So these also changed the situation. And so we wanted to assess the values and preference of people who use crack cocaine or cocaine surrounding hepatitis C self-testing, gather information on use or risks related to use and transmission in Costa Rica, and provide recommendation for hepatitis C virus self-testing, prevention and treatment. Next one, Audio, please. So as I said, it's in Costa Rica. Costa Rica, it's a small country in Central America with only 5 million populations. The research was executed in several provinces, mainly urban areas and coastal areas, trying to diversify the sample. So we work with several non-government organizations, mainly on group work. The same as our colleagues, we did individual research, group research interviews, individual interviews, sorry, group interviews, and participatory action research groups. So for the individual interviews, we contacted peers and carried out with a snowball sampling, basically. So, with the group interviews, we reached for support from several non-government organizations, mainly transgender women, as all of them is grassroots, community-based organizations, mainly of trans women, homeless people, and people living with HIV. We also did this because this situation of non-injecting has also made had a great impact on what harm reduction services are known in our country. This is because there's most of the people we interview, for example, had never ever heard about harm reduction in their lives. They don't practice any harm reduction practices. Or some of them, mainly people living with HIV, know a little bit, so they can carry out. So that's why we try to work with key populations, as they have been part of HIV projects, and they might have had more knowledge on risks and prevention and transmission of sexually transmitted or blood transmitted infections. So I wanted to talk also about how there's evidence, it's a lot of evidence on how sharing pipes for smoking crack or sharing straws for sniffing cocaine, it's also a risk of hepatitis C transmission. It's not as high as injecting for sure, but there's plenty of evidence, even though many people who use cocaine and crack don't know anything about it. You know, this transmission is higher, especially if people has wounds in their nostrils from snorting cocaine, or cracks in their lips and mouths. That it's fairly common, mainly for people who smokes crack. Next one, Mauro. So the strengths and limitations of this research has to deal, in fact, well, in the positive aspects and internal way. The first one is definitely that, as said, our organization, it's peer-based, you know, where most of our members are drug users. So that definitely makes it much easier to contact and address drug users. And it's an organization that's been going on for 8 years. We have done several researches and worked with different organizations, so we had contact with different populations, and this also helped the report, or the how it makes it easier to collect information and make this confidence with participants. You know, as I said, I'm an anthropologist. We also have a psychologist, and we have a team. There's several social scientists. So it was really interesting to carry out this research because it's mainly a qualitative research, you know, with a lot of ethnographic approaches. So it was really a good practice, and it was really interesting to get to learn about also hepatitis C, that is not a common subject of research in our country. And the positive external has to do more on amplifying the network and research of advocacy, but mainly, as the main of this webinar is to incentivize community-based research. You know, it's to show academics, to show the community in general, governments, that we, the communities, we, the people who use drugs in this case, can do and know how to do good research. So this also would help to improve the education and training and lower barriers to access to healthcare. The negative aspects has to do with mainly the pandemic. This also affected us mainly through individual interviews. All of our interviews, except for 2, we did it via Zoom. You know, and also how all the protocols for group interviews that had to make the distance and the masks and all the stuff makes it a little bit more difficult. But at the end, it came out well. You know. Also, we gave some monetary compensation to everybody that participated. We even gave some monetary compensation to the organizations that help us to contact and carry out the group interviews. This could also be seen as a negative aspect, you know, as there might be some social desirability of information provided. So we tried to work that with the report and be more clear. You know, definitely it helps a lot to talk as a drug user and address issues as a drug users and have experience, it makes it definitely much easier, not only to contact the people, but also to carry out these interviews and research. People feel more confident and they don't feel afraid and stigmatized. That it's definitely the big issue, as the negative aspects said here, external negative aspects is the stigma and discrimination. It's not easy to come out as a drug user, and there's a lot of also violence from government institutions and society. So talking about how we are also drug users definitely helped. You know? And we did notice, and well, it's not a surprise, that people who smoke crack were in more vulnerable situations, definitely. You know, this is a cultural issue, I think, in many countries where you find crack cocaine, you know, that this is how stigma, discrimination, and violence towards crack users is much higher. You know? And another internal issue was the translation from English to Spanish. I can speak good English, but it's not the same to write it down. You know? So the next one, Mauro, please. So I'll just go quick with the results, because as I said, they're fairly similar from what we saw in the other research. You know, there's little knowledge on hepatitis C. Only 3 participants of the 40-something we work with have ever had a test. In fact, there were 2 people who have had hepatitis, but they didn't know if it was hepatitis C or B. You know, so it definitely shows that there's not enough information. There's no information almost at all. You know, there was no awareness of hepatitis C self-testing. There was some awareness about HIV. Definitely, there's much more information on HIV than hepatitis. But it found it interesting because at the end, when we talk about self-testing, many people, most of the people will agree and accepted these procedures, mainly to avoid situations of stigma and mistreatment in health facilities. You know, so in fact, this picture you see there, it was a group we did with trans women. You know, they have been really empowered. You know, some of them live with HIV, and to talk on how they got treated in public health services, being trans and being drug users, it's definitely a big issue and a barrier to access treatment and to access prevention and anything. You know? So disadvantage, they say, is how to provide a strategy on education and direct support pre-test and post-test. You know, many people said that a big issue was what would happen if a person tested positive and in the home alone. You know, how we can try to educate people to go for a confirmatory test and indeed for treatment. So this is a quote that says, to get tested as you like and you feel like it in a quiet and comfortable space. I think it would be a good thing. People could motivate to get more this test, and if you get a chance to do it at home. So it definitely says it's a big issue. We also understand here in Costa Rica, laws regarding self-testing is not as easy. Our public health institution is really controlling people's bodies and how they do it. It's the same with HIV. So it definitely has to be some law, changing some laws or regulations to go further. The next one, Mauro. So the other result, just to finish, I wanted to show, you know, it's on access to testing and treatment. You know, we almost everybody said that hospitals, community public health centers, mainly this public health, you can get a free test. You know? But many people who use drugs are discouraged to access this service because of stigma and discrimination. You know? Many of them don't even know they can get this tests for free. And it definitely, you could go to a private laboratory or clinic to get this test. And that's why I put out this drawing. Now, this drawing is one of the techniques and exercises we did in the Participatory Action Research Group. And this is from a subgroup of trans women who live in central city of San Jose. A lot of them are also sex workers. Some of them are also sex workers. So I'm not going to go much into it, but the map shows mainly what the main areas they frequent and what things they do. And it's interesting to see, because you go further to asking several questions. You know, most of the points they put that it's places they use drugs, they buy drugs, they do sex work. You know, they go for support at this organization. It's called Transvida. But even though there's several public health hospitals and clinics, they didn't mention them, because they don't feel them as support. And it's because of what I said. At the end, what the government have to do, mainly at the HIV practices, is to have special clinics for key population, to have more training to this healthcare workers to work with this population. So they, most of these people who use drugs or are part of key populations would go only to these centers. So around them, they don't have much resources. And we could see that in almost every map that we work. Government institutions for people who use drugs are not a key resource. And as I said at the beginning, there's almost no harm reduction at all. So people don't feel that they need to, because they're not going to get anything. And the other one is the lack of social security as barriers to access healthcare services. That this shouldn't be a barrier at all, but it definitely, if you live in the streets, you use crack on a daily basis, it would be more difficult to get a service access. So that's another quote saying people who use too much drugs and who are on the streets are more at risk because they don't get this test. They don't have the knowledge whom or how to go ask for a test. So I think that's it, Maura. I think I don't know if there's another slide. No, I think we finished, and I don't want to go further, so we can go to have some questions. Thank you very much.
Thank you, everybody. It was just, very, very interesting presentation. Even for me that, I've seen the slide before. We're already a little bit over time, but I think if people are happy with that, we can stay a little bit longer and at least get, 3 or 4 questions from the audience. And since, I know Jake will at some point will ask everybody to turn on the camera. If you want to take a screenshot, maybe Jake can lead us into this short Q&A.
Yeah, maybe we could, Mar, maybe we could do that real quick right now, because it'll take 5 seconds. Then while we have everyone here, and then anyone that wants to stay on to ask some questions.
Sure. Yes, as you like. Yes.
Great. So, yes, we want to take a screenshot just to, share all the participants who are here. So if you would like to be in it, turn on your video now. If you don't want to be in it, you can keep your video off. No problem. I'll turn my video on, even though I'm looking quite quarantined today. All right. Give me 1 second.
I can't put my video on. The host has to do it.
I'm also blocked.
I also can't put my video on.
Okay. Anyone else having trouble?
I can.
Okay.
Please.
Amelia. All right. 1 second.
Yeah.
Okay. All right. Everyone ready? All right. Smile. And say, I don't know. Everyone say peers.
Peers.
Oh, wait, sorry. 1 sec. Pop up. Now everyone smile. Perfect. Awesome. Thank you.
Peers.
No.
We can stay like another 10 minutes if you like. You can raise your hand if you want, or but any question, reaction, or any comment from you guys, that'd be great before we end.
Позвольте мне тогда, если вы не против. Виталий Рабинчук, Евразийская сеть людей, употребляющих наркотики. Я из Молдовы. И очень интересная тема самотестирования на гепатит С. И вы правы были о том, что наш активизм направлен на то, чтобы внедрялись рекомендации ВОЗ 2016 года, по крайней мере, в моей стране, связанные с самотестированием на ВИЧ. И, по сути, оно подтверждает наши исследования, что опасения, которые вызваны с тем, что могут быть негативные последствия в восприятии своего статуса заболевания после самотестирования, они по сути надуманные. И наши исследования, которые проводил активисты из Луна, они подтвердили о том, что это все надумано и что самотестирование делать необходимо, и оно полностью совпадает с рекомендациями. Ну, это я говорю о самотестировании на ВИЧ. А здесь очень прекрасно была представлена инициатива по самотестированию на гепатит С. Это очень интересно, и спасибо вам, коллеги, это было очень полезно.
What was the question? Or the no question, or just a comment?
Comment.
Okay. Okay, so, well, if there's no other question.
Like a tomorrow.
Olga is raising hand.
Oh, yeah?
Есть вопрос, ну не вопрос, реплика, но я не могу включить видео. Организатор отключил меня, не могу видео включить.
Тебя слышно, Леха, ты можешь говорить, слышно?
Слышно. Да не, Серега, я хотел показать кое-что, чтобы ты меня понял. То есть то, о чем ты говорил, вот эти вот классные боксы у меня сейчас в руке. И вот, чтобы ты понимал, что вот это ваша идея хорошая, и вот дошла до Украины и даже до Луганской области. Вот, ну, именно вот этот боксик. Я просто его хотел показать. А? Ну, с налоксоном, да. И вот рассказать, что действительно вот эти боксики, они уже пару жизней спасли. Ну, это такое было вот просто как реплика на презентацию. Если бы включили, я показал бы. Если бы не разрешили видео включить.
May I ask about what's the... Лешек, можно я тоже задам вопрос сейчас? Что Оля Беляева, Еслун, вот Еслун, мы, какие дальше есть идеи работать с нашими странами, вот такие делать исследования для того, чтобы больше локальных сообществ подключались и учились проводить такие исследования силами сообщества? Нам это надо для адвокации, нам необходимо доказательства, и это полезная практика. Какие перспективы этой темы расширения?
Это вопрос к Мауру, наверное, да, Оль?
Да, ну Маура, там Дэниел, кто антропологом, Эрнесто, да.
Yeah. Well, it's not really about what we do. The purpose of this webinar was more to inspire like community groups to engage in research and build capacity and engage. So it's not really top-down initiative where we just, storm into countries and do research. It's just to show that, in 3 countries with very limited capacity, with a little bit of funding that we managed to raise through WHO, and based on our request, it was exactly to say, well, we want to make sure that, what do you think that, the result from HIV studies looking at self-testing are also applicable to hepatitis C. They agreed. I think we managed to show that, capacity is there. We provided very good quality results, but I think it's really up to you. And now, there are like at least 3 groups, one of them in your region or that have gone through this. They can help you if you need it, but it's more like to say, just don't be afraid. Research is just designed to look scary and difficult, that you need like a PhD to even start thinking about it. But that's exactly, a way to preserve power from the scientific community. And what we can bring is something invaluable, and it's something probably researchers just can't learn because, it's just lived experience, but we can learn how to do research. And now, at least that 3 person, you can refer to the part of our community that can, help you if you need. We can help you, but it's not really I think the question is not what we want to do in your regions, what you want to do and what we can do to help you.
Маура, спасибо. Я тогда уточню. Кто занимается вопросами, связанными с исследованиями по новым психоактивным веществам? То есть у нас наркология не откликается на запрос, да, они по-другому лечат, то есть больше калечат, то есть сложности, клинических протоколов ясных нет, люди на улице употребляют новые психоактивные вещества. Мы эти данные собираем, но вот фокус этих данных, да, чтобы заниматься дальше адвокацией, было бы полезно, чтобы помогли как бы сфокусировать эту анкету для того, чтобы можно было пользоваться результатами толково.
Well, Sergey and Danny, they mentioned new psychoactive substances. And one of the possible contribution for community is also to raise research questions. Like, for example, all the research community is dealing with something that, it's nothing to do with real life, but we can push and say, well, what we really need is a good research on this specific topic, and we want to be involved. So one of the possible contribution for everybody is just to raise good, solid research questions that are in line with what is happening in our community. So this, for example, can be framed as a research question. I think that both Sergey and Danny show that they're certainly aware about this and they can probably help you. But it's certainly we can advocate and push for this research question to be turned into research. I don't know, maybe other want to add, like Ernesto, Michael, or
yeah. I would like to say something because, yeah, I think that the main thing is to show that first we are able and we're capable to do all this kind of research, social research, produce the data that doesn't exist. At the end, most of this data, it's produced by communities, or ask for the communities, so at the point is don't stop using us as guinea pigs, and understand that we have the capability and the knowledge to do this kind of research. Most of us did. And the other thing is that learning and talking with the people and seeing how much stigma and discrimination and violence people who use drugs suffer. At the end, self-testing, it was just like an excuse. They don't even get any testing at all. So to change that, to get to a point so we can access to self-testing, we definitely need to first change the situation we are right now when they get no testing. They get no harm reduction. There's nothing. At least most of Latin America, harm reduction is non-existent. So to push further the agenda, definitely we also need this data and this information to make advocacy. So at the point, it's not research for research itself. We don't work at a university. Well, some of us may teach at university, but it's participatory action research. We do this to empower and give information to our peers to make the change a political change. So I think that's the big issue, big point.
Yeah, hi, Mauro, can I come in here?
Absolutely, sure you can.
Yeah, so yeah. Hi, I'm Prashant. I come from a small place called Sikkim, which is a part of India. The presentation was really, really good. It was like, there were a lot of things that from the community, we can do so many things. And I just like to echo what the Ernesto was trying to share. And then even I would like to, there were a lot of things talking about like who are going to fund us for our research, who is going to, provide some sort of support to us to do the research and stuff like that. So if you see the globally, then when we talk about hepatitis C, then there is not much of a data available, even if we talk technically. So there is a very, very little data available. the place where I come from, we are a very small populated state where we live 600,000 people. So in 2015, when we were not aware of hepatitis C, when we heard about hepatitis C, we started advocating to the government for free test and treat. But then government were not willing to provide free test and treat because there was not so much of data. So in 2015, what we did, we managed some kits from some pharma company, and then we did a random test among our community. Around 200 people we got tested, and we found 21 people were positive. And then we got at least a small data to go and talk with the officers or bureaucrats saying that, see, what we've been telling is the truth, that we found 21 positive out of 21 people who inject drugs. So that's how we started building our advocacy at the central level also. So in between what has happened in 2018, many of us, you remember that the government of India has launched a viral hepatitis prevention and control program, the free testing and treatment. But then the problem is the services has not yet reached to the community. So again, here the government also lacks a lot of expertise and a lot of support. So now we have stepped up and said, see, we the community have done this already, and we have the experience. We have a very little research, but then we have done it. So now what the state level government is doing, they are saying, please come with us and do the hepatitis C self-testing. Go reach out to your community and please let us know that what we can do on their behalf. So I think we, the community, can do a lot of things if we really wanted to do. But then I must say that the government is not going to come to us and say that, hey, brother, do you have a problem? We are here to help you. They are not going to say that. We are the one who should stood up and go to them, and we have to start advocating. That's how we are going to address our problem. Yeah, and those presentations were so awesome. Thank you guys for sharing. That was so wonderful. Thank you, Mauro. Thank you everyone for the time.
Prashant, let me add something. Even after we have data, well, you are quite right, there is no data. But even after we have data, we have to pay several $1,000s in order to publish the data. After it gets published at our money, we don't have a right to translate it to our native language and to give it to the communities for 2 years. I find it disgusting. Well, it's my comment, sorry.
Yeah.
May I say something? We lost majority of the data we collected in last half of year, because as you know, maybe some of you don't know, last month our office had been destroyed. It's a multiplex, a lot of organizations, and yeah, it's second time in my career. In 2008, they destroyed all data. They didn't allow me to get them, and now again the same structure of the government. I mean, the same people are. I have some echo. Yeah. Do you hear me?
Yes.
Oh,
yes.
Yeah, I have back echo in my. Yeah, so in some countries, it's really this power struggle between, how can I say, this McDonald's, McDonaldization of harm reduction, which is totally alienated from the community. It's unbelievable. I mean, they want to own the discourse. They don't like at all if we engage inside the community. This is what I want to say.
Так, я буду фетучини альфредо.
It's okay. Well, no, Prashant.
Колу возьмем ли? Фетучини альфредо. Бургер с курицей.
Аллочка, отключите звук.
Okay, unless you're asking a question, please mute yourself, because otherwise we can understand. So let's, we're really, it's really good to see people willing to stay for over half an hour after, we're supposed to be here. But maybe we can take another couple of questions if there are questions. But I think what, Prashant was saying and Ada was saying is really important. I think that the point is that we can do a lot more than just, provide bodies for research, because what we've been doing for a long time, research company or even WHO, they come out to say, can we get some of your people enrolled? And we're just basically providing bodies for research. And then we don't have access to the results. We have no control on the narrative that, come up with the result. We have no control on the policies that produce out the research. So I think it's time to say, we're happy to provide, make ourselves available for research if that research is meaningful to us. But we actually want to go further than that. We want to be in control. We want to be partner with you, and we want to be able to own the research and be able also to interpret the result, because we know that this will inform policies that have a direct impact on our life. So the attempt of this webinar was to show that we've done it with some resources made available by WHO because of our pressure. I think we demonstrated, at least in these 3 countries, we're able to produce very good, good quality results. This is a base of knowledge that is available to everybody. So also in your country, if you really want to start doing something or if you have an opportunity to do, you can refer to Ernesto, to Michael, to Sergey, to Daniel, because they've been through this. So I think it's really important if we manage to build this knowledge base and we stop being like, providing our bodies to research, but you actually are protagonists in research, since this is so, important for us because it's so huge impact on our lives. Okay, so maybe if there are no other burning question, we can close it here. We will share, I don't know, Kim, maybe we can share the presentation with all participants. I think everybody here is researched to each other for, any additional question. It would be great to know if you are engaged or you're advocating for, being involved in research in your country. We can certainly, as input, we can put some pressure on some of the big international public health organization, but also the regional level, you can find allies within your region. But I think it would be good also if with this webinar, we start, creating a little network. People are really interested, they see the point, and they want to put some time and efforts in building capacity. And we'll be happy. Let's say we hope this is just, the first step of an initiative rather than a standalone celebratory webinar, one, single event. We hope this just, will be like the first of many.
Mauro, hi. Is it that offer from input has to do also with the European countries in Europe, the European Union?
Say it again.
Is this offer that you can help us for make all this is for also for European countries?
Yeah, of course. Yeah, I think we should.
Because in Europe we have this program now of elimination and of Hep C elimination, and they give free the treatments to everybody, and but they didn't give anything for the community. And it's really very interesting.
Yeah, it's not limited to a specific region. There's an issue everywhere. Just that we want to have a part of this, and we want to be part of this process rather than just again providing bodies or getting the heat after research is being manipulated and result of being turned into like weird narrative that then influence politicians that come up with policies that have a direct impact and increase violence against people who use drugs. So it really it's relevant everywhere, including in let's say richest country.
Yeah.
Okay. So again, thank you, everybody. I think we'll send you the slides to all participants since we have your contact details. But again, just, let's see if we can use this as a platform for self-learning, self-support, and building capacity. And please let us know if there anything you can push for, or other colleagues from from the region can push for, but especially if you manage to get involved in any like research efforts in your country or region. Okay.
Thank you.
Thank you. Thank you, everybody.
Thank you, everyone.
Thank
Bye.
you.
Ciao.
Bye.
Thank you. Спасибо. Thank you. Happy to see you, lovely brothers and sisters. Thank you.
Спасибо.
Очень рада, что мы все вместе. Пока.
Bye.
Ernesto.
Bye.
Bye. Bye.